Welcome to this connective tissue disease review, focused entirely on how the boards test these diseases and how to attack the questions. This video is brought to you by Roadmap to Residency. Today we are not reteaching all of rheumatology. We are training your eye to recognize the classic lupus flare, vasculitis, and polymyalgia rheumatica stems, and to make the steroid decisions the exam asks about over and over. Keep your question bank and a trusted rheumatology review resource open alongside this video, because these patterns lock in fastest when you practice them. Let us get started. Here is what we are going to cover. First, we will learn to recognize the classic connective tissue stems on site, because these diseases are tested through tight clusters of clues. Second, we will turn each buzzword and lab value into a fast, confident next best step. Third, we will master the steroid decisions the boards return to again and again, from when to start them to how to protect the patient and how to taper. Along the way, we will walk through several practice questions and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read the stem for the pattern. Start with the last line so you know whether the question wants you to recognize the disease or to manage a flare, then read the stem hunting for exactly that. Now, the most important habit for these diseases is to hunt for the buzzword cluster, because connective tissue questions are built from tight groups of clues. A young woman with a facial rash, joint pain, and mouth sores points you to lupus. A new headache, jaw pain on chewing, and a vision change in an older adult points to giant cell arteritis. Aching and stiffness in both shoulders and both hips in an older patient points to polymyalgia rheumatica. Train yourself to see the whole cluster, not just one symptom, and the diagnosis will often name itself. Strategy 2 is to separate a flare from an emergency, and this is where careful reading earns points. First, grade the severity before you choose therapy. A mild lupus flare of rash and joint pain is a completely different problem from lupus attacking the kidney or the brain. So label the flare as mild, moderate, or organ-threatening before you look at the answers. Second, match the organ to the treatment. Skin and joint disease favors low-intensity therapy, while kidney or brain involvement demands high-dose steroids plus a stronger immune-suppressing agent. Giant cell arteritis with vision symptoms is an emergency that cannot wait for a biopsy, while polymyalgia rheumatica without those danger signs responds to low-dose steroids alone. Let the threatened organ pick the answer. Strategy 3 covers the steroid decisions the boards love, and there are 3 you must know cold. First, give steroids before you confirm in giant cell arteritis. When an older adult has a new temporal headache, jaw pain on chewing, and any vision change, start high-dose steroids immediately and get the temporal artery biopsy afterward, because treating first protects the eye, and the biopsy stays positive for a week or more. Second, match the steroid dose to the threat. Polymyalgia, rheumatica, and mild lupus need low-dose steroids, while giant cell arteritis, severe lupus, and organ-threatening vasculitis need high-dose steroids, and vision loss or kidney and brain involvement may need pulse dosing. Third, protect the patient from the steroid. Anyone facing months of therapy needs calcium, vitamin D, a bone-protecting agent, blood sugar checks, and updated vaccines. When an answer includes preventing steroid harm, it is very often the credited choice. Let us work through our first practice question, built to test vasculitis recognition. A 72-year-old woman comes to clinic with a new right-sided headache for 1 week, scalp tenderness when she brushes her hair, and jaw pain when she chews. This morning she had brief blurring of vision in the right eye, and her inflammatory markers are markedly elevated. The question asks for the most appropriate next step. Notice the vision symptom, because it changes the urgency completely. Read the 4 options and choose your answer. Then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. An older adult with a new headache, scalp tenderness, jaw pain on chewing, and a vision change with high inflammatory markers is giant cell arteritis until proven otherwise. And the vision symptom makes this an emergency because untreated, it can cause permanent blindness. Second, apply the rule. When the eye is threatened, treat before you confirm. Start high-dose steroids right now, then arrange the temporal artery biopsy, which stays positive for a week or more after steroids begin. Third, eliminate the wrong answers. Waiting for the biopsy before treating risks the eye and is the classic trap. Brain imaging chases the wrong diagnosis and wastes precious time. A triptan treats this as a migraine and misses a blinding emergency. The correct answer is to start high-dose steroids now and then arrange the biopsy. Here is our second practice question, and this one tests polymyalgia rheumatica. A 70-year-old man reports 6 weeks of aching and stiffness in both shoulders and both hips that is worst for about an hour after waking, and he struggles to lift his arms to comb his hair. Importantly, he has no headache, no jaw pain, and no vision change. His inflammatory markers are elevated, and his muscle strength is normal when the pain allows him to try. The question asks for the most appropriate next step. Notice that the danger signs of giant cell arteritis are deliberately absent. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, scan for red flags. The stem deliberately tells you there is no headache, no jaw pain, and no vision change, so there is no sign of giant cell arteritis riding along. Bilateral shoulder and hip stiffness that is worst in the morning, with elevated inflammatory markers and normal true strength, is the classic picture of polymyalgia rheumatica. Now, why do low-dose steroids win? Because they produce a dramatic response within days, which both treats the disease and confirms the diagnosis. High-dose steroids and a temporal artery biopsy belong to giant cell arteritis, which this patient does not have. Electromyography and muscle biopsy chase an inflammatory muscle disease, but here the strength is normal. Methotrexate is not first line. The correct answer is to start low-dose steroids and expect a rapid response. Now let us build a framework for the lupus flare, because these questions reward a clear system. First, confirm this is a true flare by matching the symptoms to specific organs and to rising disease markers, such as falling complement and rising anti-double-stranded deoxyribonucleic acid antibodies. Then grade it. Mild flares involve the skin and joints. Moderate flares add inflammation of the lining around the lungs or heart. Severe flares strike the kidney, the blood counts, or the brain. Second, escalate the therapy to the grade. Mild skin and joint flares respond to anti-malarial therapy, sun protection, and a short course of low-dose steroids, while kidney or brain involvement needs high-dose steroids plus a strong immune-suppressing agent. Remember that nearly every lupus patient should stay on the anti-malarial long-term. So when one choice both treats the flare and continues that background therapy, it is usually the right one. Here is our third practice question, and it brings the lupus flare framework and steroid decisions together. A 28-year-old woman with known lupus reports 2 weeks of leg swelling and foamy urine. Her blood pressure is elevated, her creatinine has risen, her urine shows protein and red cell casts, her complement is low, and her anti-double-stranded deoxyribonucleic acid antibodies are high. The question asks for the most appropriate next step. Think about which organ is under attack and how severe this flare is before you choose. Pick your answer, and we will reason through every option on the next slide. Let us break down this answer. First, grade the flare. Rising creatinine, protein, and red cell casts in the urine, low complement, and high anti-double-stranded deoxyribonucleic acid antibodies all point to the kidney under active attack. This is a severe, organ-threatening lupus flare, and it demands the most aggressive treatment offered. That means high-dose steroids plus a strong immune-suppressing agent. Now, the key distinction between the wrong choices. Continuing the anti-malarial alone is far too weak for a threatened kidney. A short course of low-dose steroids only would badly undertreat organ-threatening disease. Reassurance and more water ignore a true emergency. Every wrong choice underestimates the severity of the flare. The correct answer is high-dose steroids plus a strong immune-suppressing agent. Here is a critical exam day checklist that ties the steroid questions together, because the boards test the safety of steroids as often as the choice to start them. Before you start, protect the patient. Whenever a stem begins long-term steroids, the credited follow-up is often to add calcium, vitamin D, and a bone-protecting agent to prevent osteoporosis, to check blood sugar and blood pressure, and to make sure vaccines are current before immune suppression deepens. Then, while tapering, watch and wean. Steroids are lowered slowly and never stopped abruptly, because a sudden stop can cause adrenal collapse. In polymyalgia rheumatica and giant cell arteritis, watch for symptoms returning as the dose falls. And when a stem describes fatigue, low blood pressure, and low sodium after a rapid stop, recognize adrenal insufficiency from steroid withdrawal. That wraps up our review of connective tissue disease question strategy. Remember the core ideas, read every stem for the buzzword cluster, and let it name the disease, whether that is lupus, giant cell arteritis, or polymyalgia rheumatica. Grade every flare before you treat it, and match the intensity of steroids and immune suppression to the organ under threat. Treat giant cell arteritis before you confirm it, and always protect and slowly taper the patient on long-term steroids. The best way to lock all of this in is to drill questions in your bank, under timed conditions, and read every explanation, even on the ones you got right, with a trusted rheumatology review resource open beside you. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.